And thank you for joining us for today's discussion, the state of global benefits, trends, risks, and what employers need to do now. Before we get started, here are a few quick notes to help you stay connected and informed. Following the webinar, we'll send a link of the recording to all registrants, so you can revisit the conversation or share it with your team. At the end of the discussion, a short survey will appear. It only takes a moment to fill out, and your feedback helps us shape future conversations and deliver the guidance and clarity you expect from Hub. And now I'd like to introduce our moderator for today's event, Sarah Lugmani, Senior Account Manager, Global Employee Benefits at Hub International.
Good afternoon, everyone, and welcome to today's webinar, The State of Global Benefits, Trends, Risks, and What Employers Need to Do Now. I'm Sarah Lugmani, a Senior Account Manager on Hub's Global Employee Benefits team, and I'm pleased to be moderating today's conversation. Before we dive in, a quick word about Hub. Hub International is a leading full-service global insurance brokerage and financial services firm, ranked among the top brokers in the world. With more than 20,000 specialists across 470 offices throughout North America, we bring a wealth of expertise across risk, insurance, benefits, retirement, and wealth, all under one roof. We work with businesses across virtually every industry, helping leaders not just manage risk, but build the kind of organizational resilience that holds up in an uncertain environment. Today's session is a reflection of exactly that commitment, and we're glad you're here. The global workforce landscape is changing rapidly, and for HR, finance, and benefits leaders at multinational organizations, the pressure to keep pace has never been greater. Today's panel is going to help you understand what's driving that change and what you can do about it. Before I introduce our panelists, I want to acknowledge that many of you submitted questions with your registration. Thank you. We'll do our best to address as many of those questions as time allows. Now let me introduce the three colleagues joining me today. Dennis Guay is President of Global Benefits at Hub International. Dennis leads our Global Benefits Advisory practice, supporting multinational employers across more than 100 countries. He brings deep expertise in global benefits strategy, cost management, carrier negotiations, and local national program design. And today he's going to share some of the most compelling data I've seen on what's really happening to healthcare costs worldwide. We also are joined by Dr. Christoph Novotny, who is Chief Medical Officer for Employee Benefits at Hub International. Dr. Chris is a clinical epidemiologist whose research draws on peer-reviewed global burden of disease data, including findings from The Lancet, IHME, and the World Obesity Atlas, to forecast the health trends most likely to shape employer benefit costs through 2030. He brings a forward-looking clinical lens to today's conversation that complements the benefits and risk expertise of our panel. And Kelly Trail is the Director of Global Travel Risk Management at Hub International. Kelly specializes in duty of care, workforce protection, and geopolitical advisory for multinational employers operating in complex and high-risk environments. Together, they represent the kind of multidisciplinary depth that Hub's global benefits practice was built around, integrated advisory for multinational employers that goes well beyond traditional benefits placement. And today, you're going to hear what that looks like in practice. Here's what we'll cover. We'll start with the global benefit and cost environment, the data behind 4 consecutive years of elevated healthcare inflation and what's driving it across key regions. From there, Dennis will walk us through the reduction in USAID funding and the significant shift happening in local national populations that most organizations are not prepared for. Then Dr. Chris will bring his clinical lens to what's coming through 2030, the disease burden trends that are forecasted, evidence-based and directly relevant to how employers design and fund their benefits programs. Kelly will then walk us through the geopolitical risk environment and what duty of care actually requires of multinational employers today. We'll close with the most important actions employers can take right now, and we'll hope to have time for Q&A. So let's get started discussing the cost environment. Dennis, I'll hand it to you to set the stage for us today.
Thank you so much, Sarah. And it's so great to be here and have a conversation with everyone today on these global trends. So I want to start with 3 numbers that are pretty startling. So healthcare costs have escalated 62% from 2017 to 2026 globally. creating emerging cost challenges for many employers. The second number is 24. 24% of total costs globally are now going to pharmacy spend. Items such as GLP-1 drugs and specialty biologics are driving 11 to 12% of that specific annual growth. The third number is 67. 67% of multinational organizations note that the US costs are actually limiting what they can do and offer for their global staff. 34% of employers note that their largest concern is controlling global costs. Now, let's take a deeper look around the globe and look specifically around regions of the world and what we're seeing for trends. So first, there's a lot of numbers on the screen, but I'm going to start with Asia. I'm going to start with Asia Pacific. So this is trending at the highest rate right now from a percentage perspective, 14%. Mostly driven from pharmacy costs in Indonesia and biologics in India and an aging workforce in Singapore. I'm going to pivot and look at Latin America at 11.9%. So while it's lower than 14, it's actually the region that has the fastest cost acceleration. And what's interesting about Latin America is pharmacy costs run 2 to 3 points above medical trend. Next, let's look at Middle East and Africa trending at 11.3%. So this demand is mostly being trended upwards from the growth of private insurance. We're seeing emerging cost concerns from health capacity due to some of the funding cuts we'll get to in a moment. The next is the North America trend rate of 9.4%. So what's interesting here is while the percentage might be lower than the first three regions of the world we talked about, it's actually a higher unit cost. So higher medical costs per employee is actually a huge issue in North America. Most of it is being driven from large hospital costs, pharmacy spend, and chronic disease management. And finally, I land on Europe, where we have an 8.2% trend rate. So it's our lowest trend rate from a percentage perspective, but we see increasing and growing demand because of the lack and challenges associated with public capacity, which we'll get to in a couple moments. So the European market, 0.2%. Now, let's take a deeper dive and look at some of the driving items within the global healthcare sector. So we're going to focus on 6 specific areas. Of course, there are many more obstacles and things that compile the trend rate, but let's take one at a time and look at each one. So first, cancer and oncology. So this is the #1 cost driver for the 4th year in a row globally. 74% of insurance companies report more cancer diagnosis for people under age 40. Early onset cancer is a really growing challenge. Pharmacy and GLP-1 drugs are a huge issue as well. Pharmacy alone, like we just heard in some of the market news, that pharmacy is trending at 24% of the total healthcare employer spend, and it's growing 11 to 12% per year. Items such as GLP-1 drugs can cost up to $1,000 per patient per month. What's interesting is specialty drugs only represent 2% of the actual scripts being written, but represent 50 to 54% of the total cost. That is really startling. Heart disease and chronic conditions. This is the single largest global cost driver. $1 million catastrophic claims have gone up 50% in 4 years. And we all know that unmanaged chronic conditions lead to more expensive claims in the long run. I want to mention mental health. 73% of employers saw an increase in mental health claims in 2025. Investing in effective behavioral health claims has proven to be a 4-to-1 return on investment for employers. What's also interesting is inpatient behavioral health claims are up nearly 80% in recent years. Musculoskeletal conditions are the top cause for long-term disability, while mental health is now a leading cause of short-term disability claims in most countries. Catastrophic claims are a huge issue. What's interesting with catastrophic claims is 5% of the members actually represent 60% of the total spend. Over half of the high-cost claimants can be identified in advance, which is a good thing. However, those advanced therapies, which we'll learn a little bit about later today, like CAR-T, can cost $400,000 to $2 million per treatment.
Dennis, thank you for these insights, and I'm sure you're giving everyone a lot to think about. Given all that you shared so far, do you think we will see shrinking demand for private plans in markets where public offerings are strong?
Yeah, that's a really good question and actually leads us perfectly into the next slide. So I want to talk about a couple key trending items around the private health challenges that we're experiencing and why they're quite popular right now. So let's first start with the first statistic around speed of access. So what we're finding is in places where socialized healthcare is the main delivery system, we're seeing a big pent-up demand because of the speed to access, meaning where people are accessing care is being delayed. In the NHS, the waiting list hit 7.4 million cases in 2025. So long waits are the #1 reason why people switch to private healthcare. Across Asia Pacific and the Middle East, private care is increasingly a route to timely specialist access to care. The next is gaps in coverage. What we're finding is social systems do not always adequately cover things like dental, vision, and mental health, or general medical health in most countries. The latest cancer treatments, for example, or biologic are often rationed or unavailable through the public health system in places like Latin America, Eastern Europe, and Southeast Asia. The other thing that I really notice and I like to talk about is attracting and keeping talent. So oftentimes employers that are in socialized geographies believe that the total rewards package isn't as important as it is in other markets. But statistics tell us that's just not true. 92% of employees globally say health benefits are the most important factor when choosing an employer. In markets where employers are offering private healthcare, if you're not doing that, you are putting yourself at a competitive disadvantage when it comes to attracting that talent. And fourth is the declining public capacity. So the decline of public healthcare capacity is creating significant demand within the private healthcare sector. It's also one of the reasons, as I noted earlier in the trend slide, that we're seeing huge escalations in costs globally. 52% global insurers specifically cite declining public healthcare capacity as a key cost driver for themselves. And then finally, compliance and legal duty. So in places like Saudi Arabia, the UAE, and the Gulf markets, legally require employers to provide private health insurance. Internationally assigned employees carry specific duty of care obligations regardless of the local public system availability. So we just talked about a lot of things that seem kind of doom and gloom. I want to give people some hope, and we want to use our specific example at Hub Global Benefits to help give some promise and ease the burden. So in 2026, medical plans received initial renewals ranging from 10 to 16% from lead global carriers in the marketplace. Even with these higher trends, Hub clients paid significantly less. In some cases, single digits, and other cases, even flat amounts. Hub clients received significant adjustments from initial market renewals. Hub clients saw difference between the delivered renewal to 8 to 15% to what was actually finally negotiated. So when in challenging renewal cycles, as we are predicting with these trend rates, it is important with escalating costs, it's more imperative than ever that you are partnering with firms that have global volume, carrier relationships, and can really help you manage these high increases.
Thank you, Dennis. I want to go back to something you mentioned a moment ago around declining public capacity for healthcare. You noted that 52% of global insurance companies cite declining public health capacity as a key cost driver. Can you expand on that a bit more? That seems pretty startling.
Yes, actually, what we're seeing in markets where traditionally public health systems have been the key player, we're seeing a huge uptick in the private sector to meet that demand, right? Which is adding to the overall cost structure, but it's at least executing on some of the needs that are being very made clear by employees, and employers are really responding to that nicely.
Thank you for those insights, Dennis. Let's move to something that has been on our radar, but that many employers are still working to fully understand. Dennis, take us through the impact of the USAID funding withdrawal and what's happening with local national populations.
Yeah, thank you, Sarah. It's true. There's a lot of things happening with USAID, and the ripple effect is in many different facets. So I want to focus on three specific areas: what happened, why it matters to employers, and what employers should be doing. So let's start with what happened. So if you haven't heard, in early 2025, the US government withdrew the majority of USAID development funding globally. These cuts affected thousands of health programs across sub-Saharan Africa, Asia, and Latin America, as you know. Clinical supply chains broke down and local healthcare capacity contracted sharply in many of the markets where multinational employers have had the heaviest workforce presence. Why it matters to employers is, as we just learned, declining public capacity is increasingly overall pressuring the private healthcare sector. When these systems experience the pressure, employers end up having to fill the gap with higher premium private solutions. In addition, care has been disrupted in key markets such as Kenya, Uganda, Ethiopia, and parts of Southeast Asia. Duty of care obligations become more demanding when local healthcare capacity can no longer be assumed. And then finally, what employers should be doing. So what I recommend is, first, audit your plans and understand your coverage levels in each of your geographies. Do not assume your coverage level meets the local needs. Not all plans maintain the same standards of care. Understand how your employees can access care in their home country and possibly beyond. Review evacuation and medical assistance programs in your countries when public health care capacity has been. Work with your broker to understand how your markets have been impacted by these changes. So let's talk a little bit about local nationals. I want to first start by defining local national. Local national is a locally hired employee. For example, it's a Kenyan working and living in Kenya. At Hub Global Benefits, we have noticed a huge acceleration of local national hiring. From 2020 to 2026, we have seen a 14-time portfolio increase in local national coverage. And I bring it up because what does it really mean for benefit strategy? So when we think about global benefits, we need to take a step back and look at our different plans. So an expat plan design does not always translate to a local program or local populations. While coverage levels may or may not meet the needs on paper, the delivery system often does not meet that need for local nationals, meaning expat plans often expect an employee to pay and claim, meaning when they're at the doctor's office, at the point of service, that they are paying out of their own pocket upfront and then submitting a claim later. While a local plan, the expectation is more so a flash the card model, like we are used to in the United States. Show your ID card, get treatment, and be on your way. In today's business environment, local nationals often represent most employees on the ground. And as we are learning through today's conversation, their benefit experience directly affects your ability to attract and retain that talent. At Hub, we can help organizations establish a benefit framework for all of your employee populations to help create a competitive and harmonized benefit strategy that allows you to compete for that talent. Now, let's take a look at the cost structure. We talked a little bit about local nationals, but the other piece of our global portfolio is expatriates and third country nationals. What we thought would be useful for today's discussion is to give some actual statistics and numbers. So these are real 2026 premium benchmarks from the Hub Global Benefits portfolio. And we wanted to provide this as market context. I want to explain the chart in front of us, and hopefully you can find it useful when you're evaluating your own program. So what we've done is, for our expats, we've and our TCNs, we've broken our rate structures into different categories, expat low, for example, or expat high. Now, what this means is a low coverage or a low plan might mean younger populations or lower cost regions of the world. A high plan might be older populations or higher cost regions of the world. So the way I would look at this and maybe use it in your own analysis is, for example, when you look at the employee only rate, an expat low plan, again, might be a lower cost region or a younger population. For an employee only is $401 per month. Where an expat high plan, again, maybe an older population or a higher cost region of the world, $928. So hopefully you find this data useful when you're evaluating your own programs.
Let's pause here before we move into the clinical section. How quickly are organizations pivoting to local national hiring, and are benefit programs actually keeping up?
Yeah, as we just saw, I mean, we saw a 14-time growth, seeing organizations really pivot nicely. Approach. They're evaluating programs, they're attempting to harmonize and create a more unified benefit strategy, which I think is really essential, particularly when you have a multinational organization that maybe is operating in more than one geography outside the United States. That harmonization process for local nationals is key, where you don't want to take away a local feel of a plan, but you also need continuity across the globe, right? But I find that employers are really responding well. And I feel the private sector, in terms of carriers and solutions out in the marketplace, is really responding well to that as well. I think we have a long ways to go, but I do think the marketplace is responding.
Thanks, Dennis. We've covered the cost environment and the local national shift. Now let's look ahead. Dr. Chris brings a clinical epidemiology perspective to today's conversation, grounding our discussion in the evidence-based health trends most likely to shape employer benefit costs through 2030. Dr. Chris, over to you.
Thanks, Sarah. So Dennis illustrated the impacts on rising costs. And so where I want to reframe our conversation today is from the perspective on what most of you are likely structured, or how you're structuring your benefit coverage today. And so most of your markets, the national or the social system carries the base medical risk, right? And so your exposure isn't the whole iceberg, but there are significant places, two in particular, that you own outright. First is either your carved out or your self-funded pharmacy spend, and the other is your supplementary and ancillary coverages that layer on top of your national and social healthcare ecosystems. So as I walk through the clinical risk building over the next 4 to 5 years, the question I want you to hold isn't what's happening to healthcare costs for my company around the world, but rather the question of how much lands on the public system versus what flows straight to the layers that I'm paying for. Because the answer increasingly is that the fastest growing risks are on the very layer that your coverage is the coverage that you're sponsoring. And so let's go to the slide here where we talk about the 5 clinical risks that we should put on every global employer's radar. And so I'm going to flag each one and where it hits the global programs specifically. The first is metabolic disease. So obesity as a disease is expected to hit nearly 70% by mid-century, and diabetes roughly doubling over about 1.3 billion cases rather. And here's why this matters most for you than the headlines that suggest that you see on TV or read in the news. The treatment story is the pharmacy story. GLP-1s and other related specialty drugs such as Foundayo and retatrutide are expanding the clinical indications such as weight loss, obstructive sleep apnea, fatty liver disease, and even arthritis. And for many global employers, these sit squarely in the carved out or the self-funded pharmacy layer that you own directly. And the public health system may treat the complications of these conditions, but the drug spend lands squarely in your lap. And it's expected to compound over the next 4 to 5 years. The second piece is mental health, and we're headed towards more than 500 million people with anxiety, which represents about a $16 trillion US dollar economic cost. And for most of the global markets, the public systems barely cover mental health sufficiently, as Dennis alluded to. And the supply of mental health providers worldwide falls short of that global demand. And this means that failure almost always defaults to the supplemental or the ancillary layer of your coverage, which could be your EAP or your behavioral health rider, or even your disability coverage. And this is like the clearest example from the public health perspective of a risk when the social system doesn't catch the need of the demand of the population that you serve. The third piece is the antimicrobial or the antibiotic resistance trends that we're seeing. About 39 million projected deaths over 25 years, longer hospital stays related to like sepsis or severe infections. Much of the inpatient burden sits in the public system, but where it surfaces on your side is in two ways. One is through your supplemental inpatient and private hospitalization coverage, and the other is through your disability and absence claims that follow a serious infection. The fourth area is client-sensitive health. So heat-related deaths, we're seeing climb as high as 23% worldwide, particularly dengue, Zika, where we're now seeing these conditions move into other new geographics. And for multinational employers, this is less a cost line, but more of a map problem because it changes your locations where supplemental coverage may be required, and also a more enhanced provision around duty of care. And so that changes as these conditions move into areas where they never existed prior. And the fifth thing is the change in landscape to cancer. We're seeing this rise at the fastest rate amongst the under 50-year-old working age population. And as Dennis mentioned, there are therapies that are 6 and 7 figures, such as CAR-T, CRISPR, and gene editing. And these exposures hit you twice. One, they hit you on the drug costs because those flow directly through your carved out or your self-funded pharmacy. Because the public system rationed these or delayed these to the broader population. And therefore, people are going to reach those medications through your supplemental plan, which you cover and you provide. So you're going to get hit on the pharmacy side, but also on the supplemental health policy too. And the pattern across all 5 of these risks is that the social systems don't fully absorb things like pharmacy, mental health, advanced therapies. And these are the areas that are growing the fastest. And so those are the layers that your insurance significantly covers when the public system does not. So let's take a look at the next slide, because these risks, while they are broad in general, they don't land evenly across the world. And for a multinational organization, key variables isn't just the disease or the disease burden, but it's how much the public capacity exists to absorb them, right? So a weaker public system flows more into your supplemental layer, right? So strong public systems have a good safety net. Those who have a weaker foundation, your supplemental policies become the first line of defense. So in sub-Saharan Africa, for example, there's dual burden of disease infections. We have the rising diabetes epidemics across the world. Obesity is rising as well. And then in 2025, with the funding cuts pulling public capacity down, the demands are still rising nonetheless. And where the public floor drops to your supplemental coverage, as I mentioned, is the de facto primary plan. In Asia Pacific, cardiovascular and non-communicable diseases are accelerating rapidly, where heart disease mortality is up 91%. And in India specifically, it's one of the largest population with the highest rates of exacerbated diabetes. And across much of the region, private supplemental coverage is already the only realistic route to a timely specialist, if you will. And in Europe, mental health and oncology are rising at a higher clip. So for illustration, Nordic countries like Norway, Sweden, Finland, and even to a larger degree, like the Baltic states like Estonia, Latvia, Lithuania, and even down to Denmark, carry the highest rates of mental health burden across the globe. And the public systems in those countries are so overloaded that the private supplemental use of benefits is climbing at an exponential clip, if you will. And so that gap fill is essentially your supplemental policies. For the Middle East and North Africa, extreme metabolic cases. So in the UAE, for example, projected to have the highest rates of male obesity. We're already seeing diabetes rise 10% year over year in several Gulf states. And remember, several of these markets legally mandate employer-provided private coverage. And so your plan, again, is the de facto primary plan of use. And then finally, Latin America, metabolic disease plus relentless pharmacy inflation, which is running about 2.5 points above medical trend through the next decade. This is going to continue to be an area of focus for Latin America because that pharmacy gap, again, is the carved out layer that you own. So the design lesson here is fairly clear in that A generalized universal global benefits approach is increasingly misaligned with the location of risk. And unfortunately, the targets continue to move and shift, making it more complex to insure against it. So it's recommended that your pharmacy and your supplemental strategies be calibrated by region and at a more frequent cadence, particularly in regions where the public floor is weak and where it's quietly giving away. So moving away from disease burden and disease risk, let's talk a little bit about technology and how that plays into the ecosystem. And so this is particularly relevant to your structure because advanced diagnostics are almost never covered by the public base right out the gate. There's always a delay typically. And this chart shows the fundamental shift from modern medicine, where we see traditional devices that you see that falling blue line, giving away to advanced AI and robotics, which is that rising gold line. Care is getting more technologically intensive and expensive year over year. And the table to the right is what's arriving next. So this includes liquid biopsies, multi-cancer screenings, AI-enhanced full body images using MRI technology, digital twin modeling, brain mapping, to name a few. And from a clinical perspective, I'm very excited about these new technologies that give people a new hope, a new shot at life, if you will, to catch things either early or prevent disease in the future, or eradicating it completely. But notice that the target populations, executive benefit programs, high-risk patients, complex cases, in your role, that's not the public system, right? So these fall directly into your supplemental benefits. And these innovations diffuse into the market through that exact premium layer that you are sponsoring. So the tension for you is sharper than the U.S. Only employers, because I do anticipate while national and social systems will embrace these technologies, you're the first line of defense. And so over the next 4 years, 5 years, if you will, your supplemental plans are going to be the choice for these services, or the only option in some cases. So it's not likely until 2030 where your supplemental coverage will begin to shift the cost back to the public sector, which again means further cost to your organization. So let's take a look at the next layer. So we got our technology, but we also have changes in pharmacy in general, and some of these high cost medications, if you will, and therapies. So I'll close with in general that I call this Pharmageddon, because it's an area that continues to explode and explode year over year, and it's hard to get in front of this, right? It's very difficult to make a strategy because it changes the next year and the year after. But where we're seeing the greatest change in pharmacy is in that gene and cell therapy layer. And so there's over 25 approved therapies already, 150 that are in late stage development. They're concentrated in very rare genetic conditions in cancers currently. But if you look at the table to the right, in 2025, the average cost was about $2.8 million per patient, reaching roughly 15,000 people, with about I'll call it a $20 billion USD impact. But by 2028, the per patient price falls to about 1.5 USD, but the treating population grows to 90,000. So the total impact nearly triples, which represents about 60 billion US dollars. And here's why this is a problem. A multi-million-dollar one-time therapy is textbook example of a cost that the public system rations or delays or simply won't fund, which means your employees and their families may be seeking this coverage via your supplemental private coverage that you provide. In some cases, the drug itself flows to your carved out or your self-funded pharmacy program. There's no national system standing between you and that claim, for example. And again, on the layer that you own, you may be for the first line of coverage. And right now we're targeting rare conditions, but the pipeline that we're seeing is moving toward more common conditions like type 1 diabetes, where there are already curative measures in place in clinical trials, heart disease, a new form to eradicate hepatitis B is out there as well, with bupivacaine. And so there's a lot of different medications that are coming that are going to come with a price tag that's commensurate with the therapy. The day is coming where a multi-million-dollar therapy is just going to become part of a common condition that we see every day. And so the strategy is getting ahead of that now. And again, these are genuine gifts to patients, but because how your coverage is structured, you're going to be there's no buffer between you and the private system, right? And so a single member can reshape your entire plan's experience. So that's the clinical outlook. Again, lot of encouraging things that are foreseeable from a treatment, but again, the layers that you own can be managed with the appropriate strategies.
Thank you, Dr. Chris. That regional view is incredibly useful. Let me ask just one question before we move on. When it comes to the social healthcare impacts of USAID, what concerns you the most for employer-sponsored plans?
Tough question, but I'll stay in the lane of a clinician, if you will. So as a clinician, what concerns me the most isn't one about disease, but it's rather the early warning systems that we've had in place have thinned quite a bit. As many of you know, there's an active Ebola outbreak in the Democratic Republic of Congo and Uganda that has circulated undetected for weeks. HIV in sub-Saharan Africa has reversed its directions with hundreds of thousands of new infections projected just in the next couple of years. And here's why that matters to employers and the global community at large, is when the public system capacity drops, the risk doesn't disappear, right? It literally migrates to all of your other layers, including potential risk of those in other countries where you operate. And because some of these diseases, when caught late, become more severe and more expensive, it's your supplemental plans that quietly becomes that primary care plan, right? And again, we're a global economy, so global travel also occurs, right? So even your U.S. Health-based plans here in the United States can be impacted by some of these impacts across the globe. And most multinational employers have a mobile workforce, right? So your mobile employees near affected regions also changes your duty of care exposure, right? So if I'm in this country here and now there's an outbreak next door, a derelict of duty could apply if you're not focused on that country specifically. And so the buffer that used to catch this before has weakened. And so from my vantage point, that's the foreseeable planning problem that is impacting global well-being and global health.
Thank you, Dr. Chris. You've given us a clear view of where the clinical risks are heading. Now let's pivot and talk with Kelly about the geopolitical landscapes and how that impacts employers' duty of care, which you also mentioned, Dr. Chris. Kelly, could you share your perspective on the geopolitical landscape and walk us through what duty of care actually requires of multinational employers today?
Sure, Sarah, and hello, everyone. I want to start with a number. So 204,000 conflict events were recorded globally last year. 204,000. That's the operating environment that your employees are navigating right now. So with that in mind, I want to kind of think through 4 macro level risks that we're going to talk about. So this first one, conflict and duty of care. If your organization has people deployed in elevated risk regions, there are 3 things that you need. Documented risk assessments for every assignment location, contracted evacuation vendors who can respond before something happens, not after, and tested communication protocols. I think it's really important to note that, if something were to happen in a legal review, no documentation means no program. So just saying we had a plan, we talked about what to do, without evidence of that, that's not a defense. It basically may as well have not existed. The second is tariffs and drug supply chains. So trade policy is now a real variable in pharmaceutical import costs. The U.S. most favored nation drug pricing policy, if that's fully enacted, could push pharmaceutical costs higher in non-U.S. markets where employers have little visibility or protection today. So that's another factor to kind of keep in mind. The third is currency and inflation exposure. Medical trend rates in emerging markets are already high, as Dennis had showed us. Add currency depreciation on top, and the real cost of locally dominated health insurance premiums can spike dramatically during annual reviews. So that is something that's going to require active monitoring, not just an annual check-in. You could be quite surprised if you're just taking a look at this once a year. Really need to kind of stay on top of it throughout the year to know where things are trending. And then the fourth is the eroding public healthcare systems, which both Dennis and Dr. Chris have touched on. That 52% of insurers globally who cite declining public healthcare capacity as a key driver of rising costs. So as those public systems contract, the employer-sponsored plans are going to pick up that gap. We should plan on this being a structural shift, not a temporary disruption. So something that we really need to plan is going to be ongoing and adjust our strategies accordingly. So with that, let's kind of get practical. What can you do and what should you have in place? So every multinational employer, we think, needs 6 things in place. And I want to walk through each of these because often we find organizations, maybe have 2 or 3 of these, but often not all 6. So the first is pre-deployment risk assessment for every assignment location. So, I think that last slide I mentioned kind of elevated risk regions. I would argue you're going to want this pre-deployment risk assessment everywhere, not just high-risk locations, because, things can happen anywhere in the world, but also your traveler profile can impact the risk level of a location as well. So there's a lot to consider regardless of that assignment location. The second is a contracted medical evacuation and repatriation vendor. Again, before you need them. In the heart of a crisis, that is not the time to be picking up the phone and trying to find a partner that can assist you, right? They are overwhelmed. They are focusing on who their clients already are and not, potential new business. So you want to have those relationships in place before something happens. The third is a 24/7 assistance provider who can cover all operating regions. So again, all operating regions, right? All across the world, you want someone that your employees are able to call day and night, weekdays, weekends, for any assistance that they might need around medical or security risks. The fourth is a war risk and political violence coverage audit. Most employers have gaps that they don't know about. So the default in many BTA plans is to have a war risk exclusion. And unless you're specifically kind of targeting and requesting that exclusion to be modified or removed, it's often there. And a lot of times employers don't realize that until something happens. The fifth is an emergency response and employee communication protocol for crisis events, something that is tested and known to staff before an incident occurs. So you need to know who to contact, how to contact them, right? During a crisis, it's not the time to try to be scrolling through emails to find contact numbers or, various systems, finding out who has access to people's emergency contacts, whatever that might be. You need to have those plans in place. And then number 6 is a regular duty of care policy review using current risk data at a minimum once a year, but more often if you're in a more volatile environment. So things change, kind of that community standard can shift. So you want to consistently be reviewing your duty of care policy and make sure that you're meeting those expectations. Here at Hub, we do work with leading global assistance providers to help clients build that full duty of care program architecture, not just policies, right? So not just things written down on paper, but also, how are you really building that full program, meeting that duty of care standard? The right partner network is going to help ensure that your organization has the medical, security, and evacuation capabilities in place, again, before you need them. And finally, I just want to leave you with this, that if there is no documentation, there is no program. And as simple as that.
Kelly, thank you. That is a genuinely useful checklist, and I suspect quite a few people in this audience are taking notes right now. Just real quick, when employers say we monitor State Department advisories, what is your reaction?
Yeah, I usually start with saying that is a fantastic start, but what else? So those Department of State advisories should just be one tool in your arsenal. They can at times be politically motivated. They may not be as nuanced as you need in terms of specific regions within a country or cities within a country. They may not take into account your traveler's risk profile. So that should really just be one tool. Additionally, I always suggest reviewing Centers for Disease Control and Prevention, those advisories, certainly your global intelligence and assistance provider. And then also it's helpful and I think interesting and fun to look at kind of the Department of State equivalents in other countries. So kind of seeing other global perspectives on risk around the world.
Thanks, Kelly. What is the most common gap you see when you review an employer's duty of care program?
Yeah, so I think if I was going to pick just one, then I would say that we often don't see those pre-deployment risk assessments, particularly for locations that might be deemed lower risk. And as I mentioned before, I do think that's important to have plans for every location. You know, what is your evacuation plan? Even looking at, you know, what country of passport do your employees in that location hold? You know, does that impact evacuation routes? Things like that are really important just to think through in advance.
Thank you, Kelly, for sharing those insights. We've covered a lot of ground today, and I want to make sure everyone leaves with something concrete to act on. Dennis, I'm going to ask you to close the content portion with the key takeaways and then the top priorities.
And you've done a great job monitoring this complicated conversation for sure. So I agree. We covered a lot of information. I'm going to boil it to 4 key takeaways and then maybe give us some light, some hope, right, on how we can be thinking about this a little bit different. So let's start with the first. Global healthcare costs are escalating. It's not an anomaly. This is a systemic change we're going to be seeing, right? We're seeing it now. It requires employers to start thinking more long-term and create sustainable plans. This isn't a one and done situation for all the reasons we heard today. USAID funding withdrawal and the rapid growth of local national workforces have fundamentally changed what employers are responsible for in key markets. We need to take stock in that and start thinking about things a little bit differently. As we saw through Dr. Chris's conversation, clinical trends through 2030 are evidence-based and forecastable. Employers who plan for them now will be better positioned and be able to respond later in the future. And then finally, Kelly outlined it perfectly, the geopolitical risk demands and proactive duty of care infrastructure. As we just learned, documented assessments, contracted vendors, and tested protocols are critical in our environment today. So thank you, everyone, for sharing those key items in your discussion. I want to pivot and I want to focus on 10 actions. So it feels like we just covered a lot of areas across the globe. We focused on an array of different topics, from clinical to duty of care. But I want to talk about things that we can do as employers and give you 10 action items. So number 1, build 3-year cost plan. We are in the 4th straight year of elevated global healthcare inflation. Reacting each year is not enough. It's not a plan. Model your costs forward using regional trend rates, pharmacy growth, demographic shifts, and regulatory changes. Number 2, revisit your emergency response plan and duty of care preparedness, as we just walked through with Kelly. With the growing tensions within the geopolitical environment, it is important to take an inventory of your current programs and ensure they remain satisfactory. Review your war risk clauses, understand your triggers for EDACs, and know where your latest documents live. Don't wait for an emergency to pull them out. Number 3, invest in cancer prevention and early detection. Cancer is the top cost driver globally for the 4th year in a row. Catching it early costs dramatically less than treating it late. Expand screening coverage, remove age restrictions, and make pre-departure health screening standard for all expat and TSCAN employees. Consider global carrier carve-out policies as necessary. Number 4, build real global mental health infrastructure. The ROI is $4 every dollar spent. A standard US designed EAP typically gets under 3% usage in places like Asia Pacific and Africa. You need programs that make a real impact. Do not rush a mental health strategy. Number 5, benchmark your plans. A plan that looks competitive by your corporate policy may be below the market standards in places like India, the Gulf, or Southeast Asia. Regular country level benchmarking tells you where you stand. Number 6, look at multinational pooling and captive structures. If you're covering 1,500 to 1,000 or more employees internationally, a pooling arrangement is worth evaluating. If you have 5,000 or more employees or $3 million in annual premiums, a captive feasibility study makes sense. Both give you access to claims data and information that you cannot get otherwise. Number 7, set a global minimum standard. Define your non-negotiables in advance across all your populations. Things like coverage levels, emergency evacuation, mental health access, life insurance, etc. Then let local programs exceed that floor based on market norms. That builds equity across your workforce while letting you compete locally. Number 8, use your broker's portfolio scale. The gap between carrier initial ask for and final hub results was 8 to 15 point difference. The gap comes from volume, multi-carrier relationships, and data no single player alone can match. Number 9, get ahead of global regulatory changes. Stay engaged with local compliance and ensure you have a firm understanding. Non-compliance carries financial and reputational risk. And 10 is my most favorite. Treat benefits as a business investment, not just a cost. Employers who are winning the talent competition are the ones managing benefits strategically, not just cutting them when budgets get tight.
Thank you, Dennis. A very genuinely actionable list. So it looks like we have time for a quick question or two. Dennis, with so many changes happening globally, where should an employer focus first?
Well, I would say the first area to focus is doing a basic inventory of what you currently have. Look at both things in your geographies, your public offering and your private solutions. Make sure you understand where both ones intersect. Create a plan to identify the gaps, and then with covering those gaps. I would start there. Oftentimes, many global multinational employers just don't even know what their kind of geographic coverages look like. So starting with a discovery or inventory strategy is probably the best and quickest way to get yourself started on the right path.
Thank you, Dennis. We wish we had more time for additional Q&A, but at this point, I think we're going to have to forge ahead and start talking about closing out our conversation today. But before we close, I want to briefly highlight what makes Hub's global benefits practice truly different, because everything Dennis, Dr. Chris, and Kelly have shared today reflects how we approach this work with clients every day. We have active portfolio across more than 100 countries, 99.6% client retention, which I think speaks more volume than any other credential. Portfolio level negotiation that delivers the 8 to 50 percentage point gap that Dennis had shared with us earlier. A dedicated duty of care specialists, not just policies. Preferred relationships with the world's leading international carriers, and full spectrum strategic advisory that goes well beyond placement. If we sparked questions about where your organization stands, our team is here to help. The next step is just reaching out. So I want to thank Dennis, Dr. Chris, and Kelly for an outstanding conversation today, and thank each of you in attendance for spending part of your day with us on this very important topic. The trends we discussed today are structural, documented, and accelerating. The organizations that act on them now and that build a global benefit strategy designed for the world as it is will be in a fundamentally stronger position than those that wait. It's clear that doing so requires more than just placing coverage in each country. It requires integrated strategy, local execution, and the kind of long-term partnerships that evolve as your organizations grow. This is exactly what Hub's global benefits practice was built to deliver across health and welfare, total rewards, actuarial and pension, global mobility, emergency assistance, M&A consulting, and in-country solutions, all coordinated through a single global model. If we were not able to get to your question today, a Hub representative will follow up with you directly. Following the webinar, registrants will also receive a follow-up email and a link to today's recording, a PDF of the presentation, and all related resources. Before we sign off, here are a couple of upcoming events that may be of interest to you and your team. On June 24th, the Employee Benefits team is hosting Breaking the Cost Cycle, Taking Control of Your Healthcare Cost Strategy. This is a practical session on managing rising healthcare costs from GLP-1s and gene therapies to high-cost specialty drugs, some things we spoke about a little bit today. And on June 30th, the Retirement and Private Wealth team is hosting Keeping Pace with Washington, the latest Department of Labor updates affecting retirement plans. This is a 30-minute briefing on the DOL's updates reshaping retirement plan compliance and how to get ahead of them. If you'd like to register for either of these sessions, you can scan the QR code on your screen now. We'll also include more detail on these webinars in your follow-up email. And finally, before you sign off, please take a moment to complete the brief survey that will appear on your screen. Let us know whether today's topics were valuable, what you'd like to hear more about in future sessions, and what you'd like a Hub advisor to follow up with you on directly. Your feedback is important to us and helps us to continue delivering the content and conversations you've come to expect from Hub. On behalf of Hub International, we thank you for joining today's webinar. This now concludes our broadcast.